I'm introducing us today because we are having part 2 of our educational program. We tried to do this last year all in one session, and everyone got about a minute and a half, and I don't even think we got everybody. So earlier in the year, Dr. Sauer gave an overview of the general residency, and she'll say a few things about the program and about where we are with recruitment. And then we'll turn it over to all the fellowships and the medical students and the psychology fellowship. So Dr. Sauer, I pass the baton to you. Thank you all for being here to learn about our terrific, growing, expanding educational program. And thank you all in advance for being such a huge part of it.
Thank you so much, Dr. Katzman, and thank you for all of your leadership for us in education here. It's great to see everyone. Good afternoon. As mentioned, we will launch into an overview of our program. So focusing on our medical student education, our psychology internship, and then walking through all of our fellowships and some of our tracks. So it'll be a great overview. We have allotted about 4 to 5 minutes for each speaker. So I'll try to kind of nudge gently if we're running over time a little bit, and I'll do some of the transition handoff between speakers. And just briefly, as Dr. Katzman mentioned, we are in interview season. I know as we've advertised a few times, but we started our first interview on this past Tuesday, and we will run through the rest of January with interviews on Tuesdays and some Fridays. So we have, I think, a really great group of applicants. We narrowed it down to about 98 out of 1,000, and so really excited about growing our family. Okay, well, let me go ahead and get started then. So we will start on medical student education with Dr. Deborah Dellmore. Dr. Dellmore is our Director of Medical Student Education and Psychiatry. She's also chair of the School of Medicine and Clerkship Committee and a professor in our department. So Dr. Dellmore, I will hand it over to you.
It looks like Dr. Dellmore is not here at the moment.
Thank you. I was just noticing that also. Okay, thank you very much. All right, we'll come back to Dr. Dellmore. So let's go ahead then and move to our psychology internship. And I appreciate Dr. Waldorf is filling in today for Dr. Smart. So we have Dr. Ann Waldorf, who's our Vice Chair of Behavioral Sciences and a senior psychologist in our department. Dr. Waldorf, I'll hand it to you next. Thank you.
Sounds good. Not a poor substitute for Dr. Smart, but I will do my best. I'm going to attempt to share screen here. You all see my slides?
Yes.
All right, I may have done it. So I'm just going to be talking briefly this morning. I'm even going to start my timer, so I'll be trying to be on time task, Dr. Sauer. A little bit about the clinical psychology internship training program. For those of you who don't know, we have an American psychologically approved internship training program. We just recently last year received 10 additional years of accreditation, which is the longest time you can do, which was no easy feat, given that our visit came during COVID. So a huge shout out to Dr. Smart. I'm going to be specifically focusing today on how the training program, in addition to providing excellent training for learners, also really enhances access within our multiple clinical site settings. And not only, we have some postdocs. We don't have any funded postdocs within the department except at CBH, but there are other psychology postdocs around the institution. University Hospital, SRMC, Pediatrics has several. And so we're trying to really develop, and thanks to Dr. Towen's great leadership, the understanding that if we can get interns to stay for postdocs, then we can maybe get them to stay for positions as well. So I'm going to talk just very, very briefly about last year's cohort. We're we're on the exact same training year as the rest of the medical school. We too are in the middle of recruitment. Our final day for receiving applications is November 1st, and then I believe our first interview day will be the 12th of December. So there are lots of recruitment going on. So let's see. Let's see if I can get it to advance. Yes, I did that. Excellent. Okay, so there are 12 interns in our internship class currently. There are 12 last year. We have had that number for several years. There are some changes happening to the number of psychologist positions, so we don't know if we'll be able to maintain that number moving forward into next year, but that's where we are right now. And I just want to show how people go, those darn interns, they take up so much time and energy, but in the 12 months of the last training cohort, just want to point out that those 12 interns saw almost 1,300 unique individual patients, another 60 families, another 24 different types of groups that were led, and 2 couples. So really see that as part of their training, they also are extending access to services. Thanks to Dr. Smart for putting these slides together. So what does that look like across those individuals? So if we look at race and ethnicity, you'll see a very broad spectrum of racial identities that were served. Obviously, typical of our population, intervention with Latino, Hispanic populations, and ethno-European populations were the highest, but across all types of ethnicities. Additionally, if we look at the number, those were intervention numbers. These are actually assessment numbers. So again, assessment across all ethnicities, but particularly those 3 higher columns showing that the primary ethnic breakdown in Albuquerque, I have 1 minute, was benefited by the assessment. If you look at age group, interestingly enough, historically, the internship started out as only child clinical, but we now have 7 different tracks, child clinical still being one of them. Intervention, however, with adults ages 18 to 64 was where we saw the most. And also an interesting flip, if you look at the number of assessments, you see assessments in the from infants all the way up to 17-year-olds being the bulk of assessments. Those are done both in our child psychiatric center, but also our intern placements in the CDD. We have 4 interns currently rotating in the CDD and capturing a lot of those infant, toddler, and preschool age kids. Gender, again, not much different than the general population of our patients served, a little more females than males, but 43 transgender and 17 interventions with other gendered persons. So part of that is related to the internship placement that we have at Truman Health Center. So thanks to Dr. Brandt and Dr. Lindberg for making that possible. Again, assessments, interestingly, more males when assessments. So we end up assessing younger males and older and intervening with older females. But again, we see both transgender and other gendered populations served as well. Disability status, I think this is really important. Part of this is related to the tracks being in integrated behavioral health as well as at the CDD. So we see intervention across multiple types of disability, and we see assessment across multiple types of disability as well. So I think what it reinforces is not only is the training recognized by our largest and most important accredited body, but it really does enhance access. And the more we can focus on intern training, moving into postdoctoral training, I think the better we'll be. There is a psychologist shortage across the nation, and New Mexico has absolutely not missed that particular challenge. So thank you, Dr. Sauer.
Thank you. Thanks, Dr. Waldorf, for the overview and being present. And we certainly are grateful and very fortunate for our psychology interns and internship. Thank you. Okay. All right, Dr. Dellmore, thank you so much for joining. I'll hand it to you now. I had just mentioned we'll talk about medical student education and hand it to you as our Director of Medical Student Education and the Chair of the School of Medicine Clerkship Committee. Thank you.
Great, thank you. Good afternoon, everyone. Thanks for being here. So my presentation may not be as interesting as Dr. Waldorf's, but my intent is to do a little spaced repetition and remind you of some very important things about medical student education, and then pique your interest a little bit on where we're going with some new exciting developments. So on the bottom of this slide is a YouTube link. I don't think I have time to show it, but I spent way too much time the other day on YouTube pre-TikTok. About 10 years ago, 3 of our medical students made this really funny rap YouTube about being a medical student at UNM. And there's a couple of psychiatry references. It's kind of entertaining, a little bit off color. And then I actually got sucked into watching some Harvard ones, and then some University of Chicago one that was based, a woman singing about her work in the MICU, singing to Frozen's rather than Let It Go, she was singing I Don't Know. It was really kind of interesting to kind of get a little bit of further input outside of medicine into our medical students' lives, and kind of what their fears and what their creative ways of adapting to these things are. So I wanted to, some of you have already seen this data from faculty meeting, but I wanted to remind you that more and more of our students are interested in psychiatry. And so that's another reason why our focus on psychiatric education within the medical school is so important for that pipeline, to develop more psychiatrists and more mental health care providers and psychiatrists, scientists, and so on. So as you know, medical students need to know a lot of things before they graduate from medical school, a lot of things about diagnosing and managing disorders, and skills ranging from communication skills and developing empathy to and maintaining empathy, to the more specific skills like how to take our standardized tests and how do we support our students in performing well on our standardized exams that are necessary in order for them to perform and move forward. So this is where we have remaining needs. Those of you that are not already teaching and are interested in doing more, there's a doctoring course that goes across 3 years of medical school. So they have needs for preceptors. Sometimes it's just on a once stand-in basis. Other times it's over a semester that you can sign up for a course. In the 3rd year, there's some really interesting opportunities to just stand in for one-time teaching sessions for really fascinating doctoring sessions. So if you're interested in that, please reach out, let me know. We also have a basic science block led by Dr. Tehrani in the 2nd year of medical school. And so a lot of folks, as you can see here, teach in that. We also have a learning communities program in the medical school. And as you can see, Dr. Frazier and Armijo are mentors for our learning communities students. So they have their own learning communities and they follow students all the way through medical school and mentor them. In year 3, we always have a need for more clerkship supervisors. It's mostly inpatient folks that are supervising students. Students also have 2 2-week experiences during their 3rd year to do something called specialty exploration experience. So if you work in a clinic and you're interested in having students come to see your clinic, if they're interested in psychiatry for 2 weeks out of the year, please again, reach out to me and let me know if that sounds interesting to you. And then finally, in the 4th year, our medical students always need more sub-I, which is mostly inpatient experiences and elective opportunities. If you're doing a really cool clinic or clinical experience and you think a 4th year medical student might be interested, please let me know and I can work with you to develop an elective that will meet criteria for our 4th year medical students. So this is what 3rd year students are doing now. It used to be, that they were doing 4 weeks in a row of primarily inpatient psychiatry. 2 years ago, that changed. And now they do a total of 6 weeks, but only two-week blocks in psychiatry. 2 weeks are required that they do either at the university, either on the adult or the Geri unit, 2 weeks on an elective. They get to or select which service they want to do, whether it's VA, an inpatient unit at CPH or CPC, or CL at SRMC. We're continuing to try to partner with folks to try and see if we can develop a community outpatient elective rotation for students. They also have teaching sessions on Wednesdays. They have a couple of other really exciting clinic experiences, including PES and a substance use disorders treatment clinic, either at ASAP or at Recovery Services of New Mexico. So lots of things the third year students are doing. So one of the most important things we can do for our students as we supervise them is provide fair evaluations. And here's some of the spaced repetition. I wanted to, again, empower you to take the time to really think about each student when you're evaluating them, think about observed behaviors, and try to use each anchor individually as you're rating the students, both in their sort of numerical anchored prime evaluation. We use a developmental rubric called the RIME to evaluate students. We added a P on the front of it to also look at professionalism qualities. So when you're doing the prime, again, take your time, start by mentally identifying specific behaviors that you witnessed the student perform, and then examine each rating area and grade the student at below novice, novice, expected, or advanced clerkship student skills. It's okay if you do not applicable, it doesn't harm the student's grade. I want you to be aware of this error potential. I see it sometimes when evaluators just go down and they say, well, the clerkship student was an expected clerkship student overall, so I'm going to give them all threes all the way across. So this is less helpful, I'd say, for the students, because it tends to create a little bit of difficulty in using assessment as feedback for the students. So why do we provide thoughtful evaluations? Why do we also provide a very thoughtful narrative experience? Because it helps me to help the students if they know where they are specifically in specific areas. It helps me to advise them. It also helps them grow. If we have the growth mindset we're all trying to work towards, if we don't know where we're making mistakes or where we need growth, then it's hard to focus our efforts in that direction. So often students are disappointed a little bit when they get all fives or all advanced clinical clerkship student ratings, because they don't really know where to improve and where to focus their efforts. So when you make the narrative description, it's important. Parts of that I select to go into the student's dean's letter, which are more and more important, their clinical evaluations, for helping them to achieve residency placements, because now that step one has gone to pass-fail, they primarily have their clinical evaluations in clerkship year and their narratives from their grades to use as part of their application for residency positions. And hopefully most of you know that psychiatry, now that it's so sought after, is becoming a very competitive specialty. So they need good grades that are based on competency, observed competencies of the student rather than personal characteristics descriptions. So that's what I said here. I also want to point out that we have fourth year student experiences. We have both their sub-internship, which is supposed to prepare them for residency. Mostly our psychiatry applicants are doing sub-Is on one of the inpatient services. Sometimes we'll have ER students interested in going into emergency medicine doing sub-Is kind of later in the year as well, because they don't have an emergency medicine sub-I available, and doing one sub-I is required in the fourth year. We also have elective experiences. Currently, we only have 3 electives. We have CL, ASAP, and outpatient, thanks to Dr. Armijo and the other outpatient folks who have come together to offer that. Again, if you're interested in offering an elective experience for fourth year students, please let me know. I can help you do that. So we're also aware, like the residency, of trying to protect our students' really help them focus on education and help support their well-being. So these are some of the things that we're trying to do. We're really trying to support their test taking ability, since we know that if they do well on the shelf exam, they will do well on step 2, which is an important part of their application for residency. We're also giving them some study time, and in general, psychiatry rotation is received as a very good rotation for work-life balance. So fortunately, we have a little bit less work to do there. Here's medical student contacts. If you need to reach out to us, I want to give a special shout out to our coordinator, Daniel Jordan. I already mentioned Dr. Tehrani is now running the neuroscience block, which has a new name this year. It's starting in 3 weeks, so that teaching will begin very shortly. And then thanks again to Dr. Valles and Dr. Armijo, who helped support the clerkship experience. So final slide. So we have some exciting positive results. I just shared with some of the data of the GQ with you. So our recently graduated 4th year students gave a lot of positive feedback about the clerkship experience and the basic science experience in the 2nd year. So we're doing great. I also just participated in an evaluation of our clerkship from last year, and that's going through the curriculum committee, and that looks great. We've got nothing but really positive feedback for that. Some areas that we're expanding our efforts. We are really aligning with the medical school's efforts to provide more structural competency teaching and support within the curriculum. And thanks to Dr. Haynes, who's giving this mental status exam teaching session with this diversity lens that the students are really receiving well. We're also hoping to add community psychiatry as a 2-week elective in the 3rd year clerkship experience. So more to come on that. We're doing continuous quality improvement. That's what CQI stands for, at using high quality questions in our teaching and in our quizzes, our assessments, for helping support good shelf exam performance and thus good step 2 performance, and thus competitive residency placement. We want to keep working on timelier evaluation feedback, getting our evaluations in a timely fashion and a quality fashion from our evaluators. So thanks again to all of our evaluators for doing so. And then finally, we're going to keep working on our efforts to provide fair evaluations and address the clerkship grading disparities that we noticed a few years ago that it's kind of nationally an issue. We're going to keep working on that. So thank you for your attention. Did I stop my share? No, I did not. Okay, there we go. Okay, and I'll hold any questions till the end, or you can certainly ask me questions via email or type your text. Thank you.
Great. Thank you, Dr. Dellmore. Thanks for all of your care and dedication for many years towards medical student education. We're very, very fortunate. Okay, so we'll move on to our fellowships now, and I apologize for the leaf blower outside my window. So we will next go to Dr. Kimothi Cain. So she's an assistant professor here in our department. She's our program director for the Child and Adolescent Psychiatry Fellowship and also medical director for our outpatient child and adolescent psychiatry clinic. So I'll hand it to you, Dr. Cain, to share more about our child fellowship.
Thank you, Dr. Sauer. And thank you for the introduction. So we have an extraordinary group of child fellows. We're so proud of them, and it's really an honor every day to coordinate the child fellowship. So thank you for joining. I just want to go over a couple of things that have been a crisis and throughout the world. And so those of you who work through PES, you know that the numbers of children that we're seeing in adolescence has gone up extraordinarily high since COVID, and even before that. And COVID was really the tipping point. So in October 2021, there was a declaration for a national public health call. There was ACAP, American Academy of Peds, and Children's Hospital Association, who came together and said, we have a state of emergency in children's mental health. And during the span, during early COVID, ED visits went up extraordinarily high for children and then for adolescents. We saw fairly drastic increase, as we did with suicide attempts. And the group that suffered the most are females, and within that group, Black females. During COVID, there were many of us who would have follow-ups with families, and there was a new guardian or a new adult, and it was very hard because those were kids who had lost a parent to COVID. We would see this every week. It was a really, really tough time for children. So in addition, starting a year earlier, and really, like I said, this predates the current crisis. It didn't just suddenly happen, right? This has been worsening and worsening over time, is looking at high school students. Almost 37% reported feeling depressed and very sad. And 18, almost 19% had seriously considered suicide. That's very frightening with a young, impulsive brain. So the proclamation has called for several incentives to make some changes in infrastructure and provide care for our young people. One of the big concerns, ongoing concern, is the severe shortage of mental health providers for these kiddos. In addition, the Kids Count data book that came out this year showed that we are now 50th. We were 49th last year, and we are now 50th. And so this looks at economics. This looks at child health, including deaths from firearms, suicide, education. And this looks at family and community well-being for these children. We are really struggling. And so there's a shortage of child psychiatrists, and except, as you can see, certain areas in Hawaii, there's a high shortage, but there's a few more people who have navigated that way. And then, of course, the East Coast. And the concern is that many psychiatrists, if you look at average age in New Mexico, it's 56. So people will be retiring at some point. Many of our child psychiatrists are working part-time or even very limited time, or have retired. So if you look at this number, it says total number of child and adolescent psychiatrists. This is not accurate. This came out in 2019. And even then, there were 30 of those who were practicing very part-time or working for IHS in Arizona. So that number is not quite accurate. So we have several different means to try to train fellows and clinicians who are able to take care of these very fragile families. And one of the paths is our child track, which is a combination of general psychiatry training and fellowship. So they apply once in their internship year, and they automatically match to the fellowship. So that during that time, people will have more opportunities to have exposure to not just child psychiatry, but pediatric medicine, and then to be able to have connections with people throughout their training. Of course, there's the fellowship. The traditional path is 4 years general psych and 2 years of fellowship. Most of our fellows historically have done the fast track option, which is doing general psychiatry and then applying again for the child fellowship. So our fellowship size has increased. So we have 9 spots now, and we currently have 7 fellows. So with the expansion, we'll be recruiting a few more people this year. So we're very fortunate about that. And then, so the curriculum is comprehensive and very diverse. So there's a lot to learn during 2 years of fellowship, and predominantly the first year is a lot of inpatient experiences. But in addition, there's also really important opportunities that they'll be a part of, including outpatient and evaluation of very young children, which has really been a draw for our fellowship. Not many fellowships offer evaluation of children 5 and under. And then also in our second year, we have a lot of flexibility for electives. I feel that that's really important, so that our fellows have a chance to, if you will, try things on. Once we're attending, so it's a little bit harder to do that, but they have quite a few outpatient experiences really targeting patients that they will see when they start practicing. So our focus on training is leadership, education, teaching, advocacy, and wellness. And so one thing that's really important in adult learning theories is how we learn. And one of the ways we learn is actually by teaching. So a lot of our fellows are key in Department of Peds, teaching resident school and adolescent medicine, general psychiatry residents. Well-being is very important to us. And so we have a very supportive group of people, faculty, and each other. And so I think that's very helpful. And then we talk with them about their work-life balance and make sure that they're doing well. And then leadership is something that was really key to my development as a CL fellow. And it's something that I'm carrying over to the child psychiatry fellows in terms of having more experience as a junior attending, while they have an attending present to help kind of coach them and help them model, what it's going to be like stepping out of academia or out of their fellowship. And then we continue to have really fantastic survey results. A few things that we're working on is more opportunities for fellows to work with and learn how to treat kiddos with neurodevelopmental disorders, which it's the referrals we get are extraordinary. We have so many referrals to evaluate kiddos for autism, different developmental delays. And then one thing that we have been talking about a little bit is a discussion of a pilot project, which is a 4-year training path to child psychiatry. It's in the works and being talked about, not necessarily at UNM, but it is something Dr. Sauer and I are talking about. So happy to fill you all in if you have any questions. And big thank you to Desiree and Sean. I couldn't do this without you all. So thank you so much. So we have a fantastic and solid group of leaders, and we're welcoming, as you can see at the very bottom, Dr. Nem will be starting next Tuesday. So she will be joining our clinical leadership in the outpatient side.
Great. Thank you so much, Dr. Cain. Really appreciate your leadership. And as mentioned, also a graduate of our Consult Liaison Fellowship. So we'll use the transition to move now to Consult Liaison. So Dr. Emiliano Valles will be talking with us. Dr. Valles is an associate professor in the department. He's a medical director of our inpatient Consult Liaison team. And as earlier mentioned, one of our co-directors for the med student clerkship. So I'll hand it to you, Dr. Valles. Thank you.
Thank you. I appreciate it. It's nice to meet some of you who haven't had the chance to say hi to. Like was mentioned, I'm one of the psychosomatic medicine fellowship graduates and currently one of the attendings on the inpatient consult psychiatry service. Today, I'm just going to be introducing you to our fellowship opportunity. Some of you might ask, what is consultation liaison psychiatry? We are the 7th, and I think, as the last time I checked, the newest psychiatric subspecialty accredited by the board. It is a new fellowship, but it is a very old clinical consideration. Even as long ago as the 1600s, our cardiovascular researchers were recognizing that perturbations here can cause affectations here, and affectations here can cause perturbations here. And so we've known that the mind and the body interface for a very long time. However, we don't necessarily treat the mind and the body as being connected from an infrastructural or institutional standpoint. Mind at our mental health center is literally across the street from the rest of where we practice medicine. And so one of the things that we do in consultation liaison psychiatry, which has undergone some terminology changes over the years, historically had been referred to as psychosomatic medicine as well, is we emphasize the interface between the mind and the body. We try to emphasize kind of an understanding of how underlying psychiatric issues can cause medical symptomatology via conversion and somatization, how it can complicate medical care via illness, anxiety, symptomatology. And we also emphasize an understanding of the fact that there are underlying physiologic processes that are responsible for the generation of emotion and cognition, and that they are altered in the context of disease, and we can change them with psychopharmacology. And so we sort of nerd out about that from an academic standpoint, but from a clinical management standpoint, our utility lies in the consultation liaison role. placing psychiatric clinical providers in a location where we can assist our clinical colleagues in caring for patients who have psychiatric illness at the interface of medicine. At the moment, from a residency education standpoint, we have two mandatory PGY1 and PGY2 rotations, both here and at the VA, but we also offer elective CL rotations for our upper level residents, including a CL chief resident opportunity. Part of this discussion is to sort of kind of pitch the idea of a consultation liaison fellowship. And one of the things that we like to emphasize is that psychiatry in general is sort of starting to increasingly be seen as consultative in nature. And so training in consultation liaison psychiatry would position you very well to step into collaborative care models, step into registry management, to step into telemedicine-based teams, subspecialty clinic integration, clinical care in a general hospital setting, as well as Dr. Cain mentioned, can provide education about the kind of liaison skills that would prepare you to step into professional and administrative roles. From a clinical utility standpoint, it also improves our visibility. And so one of the things that we forget is that we develop a skill set that has a lot of benefit. And because we apply our trade in a location that is kind of limited to psychiatric clinical care providers, we don't necessarily get the chance to show off. And it can be incredibly gratifying when the nursing staff or the physicians on a medicine floor recognize sort of the benefit and value that you bring to medical clinical care. And that is sort of cool to see. You become the standard bearer and kind of the face of psychiatric clinical care, which can improve the visibility of our field. In addition, from a job protection kind of into the future standpoint, it doesn't hurt to lean into the physician aspect of a psychiatric physician. And so understanding the interface between psychiatry and medicine can allow you to leverage that educational achievement. Our fellowship is a one-year fellowship. There are basic requirements for applying, including graduating. And our clinical rotations kind of exist at two main clinical sites here at UNM Hospital, as well as at the VA MC Medical Center. Redundant. It consists largely of inpatient consultation with the addition of outpatient primary care integration rotations and the opportunity for subspecialty clinic integration plus echo exposure. This is an example of our weekly schedule, but keep in mind that the interface between psychiatry and medicine is vast, and therefore we want to offer many different kind of a large variety of rotation options to tailor the fellowship to your specific clinical interests. And that can range from kind of transplant, psychiatry, endocrine, cardiology, bariatric, kind of specific medical, clinical, medical intensive care rotations, that sort of thing. Our fellowship is now 10 years old, and over that time, we've had the opportunity to train 7 fellows. We haven't necessarily had a fellow in, I think, the last 2 or 3 years, but I think that we are still increasing kind of the visibility of consultation liaison psychiatry and interest in consultation liaison psychiatry within our trainees. And over the last 2 or 3 years, we've had a large number of trainees go on to match at competitive locations offering CL fellowships. Currently, we're also working on expanding the kind of number of faculty that are involved in education. You can see kind of who is currently involved at the moment. Dr. Hager is currently the fellowship director. I'm the associate fellowship director, and Dr. Geppert is the site director over at the VA, with Dr. Vicenti also functioning over there. Recently recruited Dr. Christopher Mantrek as a new attending, who's going to help to increase our education in psycho-oncology. Perks of the fellowship, like I mentioned, I think that it prepares you to function kind of confidently at the interface between psychiatry and medicine. It has broad applicability to multiple provider settings. I think that as part of the fellowship, we provide ample opportunity for publication, education, and research. You're allowed to present during grand rounds, and then we often encourage you to kind of publish and present at the national conference. We provide daily clinical supervision and teaching, career mentorship, and leadership preparation. And that's all I got. Thank you, guys.
Great. Thanks so much, Dr. Valles, for the overview of CL Fellowship. Okay, so we'll go ahead and move on. We do still have a few programs to go. And so I think if people are able to hold the presentation to 3 to 4 minutes, that would be great. I know we could spend more time on each one, but I'll go ahead and move to our Addictions Fellowship next. So Dr. Bellelizabeth Foster, who we're grateful came back to UNM this year and is a addiction psychiatrist and assistant professor in our department, as well as a child and adolescent psychiatrist. I'll hand it to you, Dr. Foster, to talk more about the Addiction Fellowship.
Okay, so I'll get started, and fortunately, I hate PowerPoint slides, so this ought to be really fast. Let's go to the slideshow. I want to go past this really fast. So this is just basically the introduction to substance use and drug overdose in New Mexico. And what's interesting is when I left New Mexico, the focus was actually on the growing methamphetamine overdoses. And now there's significant fentanyl overdose. Just today, we got an HSC Connect that showed that we're getting an increase in poison control calls secondary to marijuana edibles in this area. This is a really interesting graphic that shows alcohol and drug mortalities. I like it because it doesn't just focus on New Mexico. It kind of shows us over a period of time what areas have the highest overdose rates. I think it's important to look at California because that's changed over time, and they've implemented, based on taxes, some new services called incidental medical services that allows treatment for detox, which has improved overdose rates and declined. This is a map of addiction psychiatrists per 100,000. If you look at New Mexico, you'll show that it shows that we actually have the highest in the rural areas. It's very indicative of the fact that we have had trained addiction psychiatrists. Why choose addiction psychiatry? I think that primarily the ability to educate within your practice, community, and other clinicians, the ongoing research. There's a new study out through NIDA, it's called the ABCD study, and it actually is, they've taken and very wonderfully started at young ages and are going to follow kids with neuroimaging over a period of time and look at how there's neurodevelopmental changes based on substance use. We've got development of new pharmacotherapies. Dr. Bott is a leader, national leader, and creating more treatments. Psilocybin has been in the news, but his areas are quite significant, and fellows are able to participate in this. And I think finally, just being able to take care of a marginalized population, not only within medicine, but also within psychiatry. I don't know how many psychiatrists, even within our institution, have their Suboxone buprenorphine license. And so we really do have a role to play throughout. This is before he chose New Mexico. He is actually from Arizona. He's going to return to Arizona. He's going to be triple boarded. And when he goes back to Arizona, he'll be one of 2 child and adolescent addiction psychiatrists throughout the state. So we were able to track him and attract him for the training. And it's very nice to be able to see that New Mexico will send somebody back to another state, and hopefully we'll get an exchange and attract another resident for training. Dr. Pickrell is from Utah, and he chose addiction psychiatry fellowship basically on the complexity of his patients. Recently, we talked about methadone patient that was on 150 milligrams daily and was using 20 to 30 fentanyl pills of unknown origin. Severity, we're so lucky in New Mexico and at the University of Mexico to have the diversity of training sites. We have a widespread ethnic background of our faculty, of our patient populations, and we do excellent care related to limited public services and resources. I think this is an example of our training, and it's a monthly schedule. It's just a 3-month rotation, and it shows not only our clerkships or our rotations, but it shows our attendings. Dr. Pondy is triple boarded. Dr. Romo is Dr. Pondy's child and adolescent. Dr. Romo's triple boarded in psychiatry as well as addiction medicine. We work with Dr. Jacobson, who's family practice, and Dr. Godomsky, who's preventive medicine. And so we have this really rich group of attendings. Anybody interested in thinking about the fellowship, I think the weaknesses that we have in other fellowships experience this, and that it's a 5-year. It adds to your training, and I think that the rewards outweigh, the cost in that brief period of time. And if anybody would like to explore it, we are just willing to talk to all of you at any time and set up mentorships within the department. So that was good. That was short.
That was great. Perfect timing. Thanks, Dr. Foster. Appreciate your presentation and presence here. Okay. Let's go ahead and go to Dr. Abbott. We'll talk about the geriatric fellowship next. So Dr. Abbott is a professor in our department. He's the division chief for neuromodulation and geriatric psychiatry. I'll hand it to you, Dr. Abbott.
Thanks, Dr. Sauer. 1 second. A single slide. So we need geriatric psychiatrists in New Mexico. 8 of us currently, and by 2030, we'll have 25% of the New Mexico population over 65 years of age. We're inundated with referrals. We have to be very selective about who we accept on an outpatient basis, just because we don't have enough providers. So there's a strong need, not only in New Mexico, but nationally as well. So clinical services, I'm really happy to say that we have a successful integration with advanced practice providers, Aaron Conklin and Ross Brown. We're going to have another advanced practice provider will be joining us in November. And I think this is the way of the future, basically to kind of extend services. And we're really kind of focusing on a collaborative approach. We're also integrating with neuropsychology. We'll have Dr. Dumaj officially join our clinic at the end of the month. And we're going to be able to kind of better access neuropsychology services for our seniors clinic population. In neuromodulation, we do neuromodulation across the lifespan, but it definitely does have a home within the context of geriatric psychiatry. It's a required rotation for the geriatric psychiatry fellowship. So for residency, we focus on inpatient, Dr. Farrar and Aaron Conklin during the 2nd year. Dr. Farrar is doing an excellent job providing some really good neuropsychiatry-based geriatric psychiatry training during the 2nd year. In the outpatient clinic, it's myself, and Jeremy Miller is helping us out, is also Megan Shed for the year. So we have a really nice outpatient clinic structure. For the fellowship, we share responsibilities at UNM and the VA, and we really try and integrate imaging, and we have a real strong rotation with neuropsychology. There's a talented group of neuropsychologists over at the VA, and Dr. Miller is really benefiting from a lot of their didactic experience on Wednesday mornings. Part of the rotation is palliative care hospice. We both do inpatient and outpatient. I've already mentioned we have a strong neuromodulation focus. Educational initiatives, I want to highlight our future fellow, Dr. Wales Haynes, is going to pilot some geriatric psychiatry educational initiatives during the first and second year. And we're hoping this has a nice impact on everybody's experience within geriatric psychiatry. We also are unique in that we have a lot of existing research opportunities for both residents and fellows. We have 2 R01 level projects focused on ECT and imaging. And I want to shout out to Dr. Quinn for his work in late life depression with accelerated TMS. And that is my presentation.
Awesome. Thank you, Dr. Abbott. Very efficient and definitely an awesome opportunity with the geriatric fellowship. So, okay. All right. Thank you. Let's go to Dr. Nina Higgins then next for the reproductive psychiatry fellowship. So Dr. Higgins is an assistant professor and the program director for our reproductive psychiatry fellowship. Thank you.
Can you guys hear me?
Yes.
Yes. Okay, great. So I will try to be brief so that the people after me can also have some time to speak. So for those that don't know me, I'm Dr. Nina Higgins. I am the fellowship director for the Reproductive Psychiatry Fellowship. So new this year, so the first year we were a combined reproductive psychiatry and infant mental health fellowship. I lost my co-fellowship director who was infant mental health trained. So now we've made this change to make it primarily a reproductive psychiatry fellowship, but there are still opportunities in our at UNM for infant mental health electives if a fellow does have interest. So what is reproductive psychiatry? So treatment of mental health disorders in women during times of hormonal transition with emphasis on the peripartum period. I think people can sort of think, oh, well, that's just postpartum depression, and that's all that is. I mean, that's really the tip of the iceberg. There are some women that have, no history of mental health disorders in the past and then have a postpartum depression. And I think that's what people mostly think of. But in general, we are seeing, patients that people in general psychiatry and the subspecialties are seeing mood disorders, bipolar disorder, primary psychotic disorders, substance use disorders. Those patients get pregnant. And so we're seeing those same patient population, but now with the medical complexity of pregnancy and breastfeeding. And a lot of people feel really uncomfortable with that and often take patients off their medications, thinking that that's the most safe option. So education in this area is our main focus. So briefly, it's a year-long fellowship. Currently, we are non-ACGME accredited, so we don't go through the match in the traditional way. It's open to psychiatry residency graduates. The bulk of the education is going to be in perinatal psychiatry clinics, but there are 2 substance use disorder clinics for women that are both pregnant and in the postpartum period, which I think is a strength to our program. There will be a half day for psychotherapies in either a topic in reproductive psychiatry or infant mental health if a fellow has interest in that area. So more of the attachment between baby and caregiver. You'll also have a half afternoon for some sort of scholarly project. And then you'll have a half afternoon for an elective outside of the peripartum period. So things that for example, my current fellow, Dr. Rose, is doing a premenstrual dysphoric disorder and perimenopause clinic. But if there's interest in, for example, gynecological cancers or eating disorders, those are also things that we can offer. And then they also, our fellows participate in a weekly didactic series, which is a nationally recognized program called the National Curriculum for Reproductive Psychiatry, where you gather with other fellows around the country and you get an expert every week that gives you a lecture, which is a really great opportunity that we're involved in. Other interesting things to know about our fellowship is that the fellow is not hired as a traditional fellow, but a visiting faculty. This means that the fellow can bill independently. They can supervise trainees and also bill under trainees as well. Because of that unique aspect, they can act as an attending in PES for extra money if they have interest. I know a lot of our fellows have had interest in doing that. And then the other thing that I think is really unique to our program is we have a really strong relationship with psychology. Dr. Crawford is my counterpart in our Journeys perinatal clinic. And so the fellow gets a lot of expertise in the psychotherapy and groups and things like that as well. So wish I had much more time to talk with you more about this very interesting field, but I am certainly available to anybody's questions. Always welcome to reach out to me through Tiger or email.
Thanks so much, Dr. Higgins. Yes, I know we could definitely delve in more with each subspecialty, and we're really fortunate to have a reproductive fellowship here. There are not many in the country. Okay, so we're right at the end. We will just do one more section then on integrative psychiatry. And I'll turn to Dr. Pentz then for the last section. Thanks, Dr. Pentz, as the leader for integrative psychiatry here and associate professor in our department.
Can you hear me now?
Yes.
Okay, I will try to be brief as well because I know we have just a few minutes. So integrative psychiatry elective, why is it not forwarding here? Okay. What is integrative medicine in mental health? And I thought I'd add a couple slides around that because we use the term integrative medicine in different ways, both in family practice and in other arenas. What I'm focusing on is looking at integrative medicine for mental health that uses a combination of lifestyle changes, therapies, and seeking to support the healing path for the whole person. Its focus is looking at complete mind, body, and soul using an evidence-based approach to improve one's wellness and health. I wanted to show this so you could see how it interfaces. It's not to exclude conventional medicine. It is to include it, but also emphasize the importance of there are other ways to help support the person that you're seeing, whether it's doing more of an integrative model or emphasizing self-care. This is another slide that really helps you to see. We just finished 6 weeks of nutrition and looking at GI health. We will be looking at cultural beliefs. We will also be looking at different avenues here that are supported here from a more integrative perspective. So I did interview someone who mentioned these are the reasons he just completed the elective. And here are some of the thoughts that he had in terms of sharing. He took it because he wanted to provide better care. He wanted to provide a common ground to communicate with the patients that he sees, have a level of understanding about different strategies and supplements that patients bring to the table, have an increased awareness of safety issues when using medications and people come in with supplements. I won't go into this, planting seeds. We've been doing this since about 2018 and 19 more formally. Prior to that, it was an elective for 2 weeks up to a month. I think even a 6-week opportunity was offered. I will go and just talk about the current group. We have currently 5 third-year adult residents, 1 child fellow. It is an all-year elective. If people are interested, I'm happy to discuss with Dr. Sauer and the residents that want to maybe do more of a hybrid where they just do maybe 6 weeks or a month. I am looking to be open about that going forward. The format is similar to our last year, and I have a list of some of the lectures that are provided. It is currently in a hybrid format so that presenters are either on Zoom or in person. We had our first live session last week, and it was well received. And we're hoping to do that more often, as there's a whole other dimension when we're able to do it in person. And I want to invite all who are present and those that maybe hear about, you're welcome to come, regardless of your background, to see if there's topics of interest throughout the year. This is a brief overview of what is explored throughout the year. We start out with an 8-week mindfulness meditation. Dr. Aronella continues to join us, and then we do a joint teaching. There's nutritional psychiatry that we just completed. Dr. Lin has agreed to continue with these lectures. Breath and work and yoga for mental health is to be explored. We're actually introducing Ayurveda as well as the use of spices and food as medicine next week. In the next 2 weeks, Chinese medicine will be in the spring, as well as an introduction to Qigong. What's another piece that's really exciting, I've connected across the way with UNM, and Chio is an incredible man who's put this program together about Indigenous medicine. He's allowed residents to come to be a part of this at no cost, to learn and to actually be present in many healing traditions. So there's an opportunity to participate in ceremony as well as healings. We did not do it during COVID, but as of this past summer, going forward, it is available. I did participate in some of the activities. It was truly very beautiful. There's also art and medicine, exposure to herbal medicine, and hypnosis. There are more topics, those are just a few. Many of the residents have spoken how the mindfulness meditation was the best way to start the third year residency. It created the necessary support to deal with the stress. We chose the 4 o'clock on Tuesdays, even though I know it makes it for a long day for people, but it is allowing the residents to not be pulled away for clinical duties. And there's many tools that are offered, including nutrition and supplements that help create elements of self-care for themselves. And I'll keep moving on. Expectations. Attendance on Tuesdays at 4. There's an online course. It's about 100 hours now. And you need to complete about 80% with a 70% passing grade. And I do want to let you all know it's open to all residents and fellows, but due to time constraints that people have in their first and second year of training, overall, it's been more accessible to third and fourth year residents. There was one second year who actually completed most of the program last year, and kudos to her. So I already talked about the first two. Then we have a reflective writing essay on the experience about the year that's written towards the end of the whole experience. A scholarly presentation of a topic of interest is also requested, and that's usually in March or April, and then the mindfulness meditation that I already mentioned. So we do have a limited clinical component at this time. If people have ideas about how to make this more possible, here are some ideas that we've been bantering around with, and I'm happy to have dialogue with people if they have other ideas. We have had some success. I've brought in a live patient, and she was able to share about her journey about reducing the antidepressant she was on with the support of supplements. I've had faculty reach out to me regarding cases, and I'm happy to be a resource in that regard. Happy to formalize a time to make that open to other individuals, and would welcome suggestions going forward. Thank you for your time.
Great. Thanks so much, Dr. Pentz. Thanks for helping us end our whirlwind of presentations on the many great fellowships, programs, and tracks that we have. So thank you so much, everyone. I know we ran a few minutes over, but again, appreciate your attention and for all you bring to our program. We'll let you migrate for the afternoon. If you have questions or follow-up for anyone today, please feel free to reach out to them directly. We also have the special interest group for residents that can be a good space to explore some of the fellowships more. So thank you all.